Welcome everybody to the Top 20 Studies of 2024. I'm dermatologist and hair loss specialist Dr. Jeff Donovan. This is an annual event that we hold every year, and it celebrates some of the top studies of the year gone by. And I want to thank you for attending today. This webinar is going to be recorded, and we will post it to our Donovan Medical YouTube channel. And we'll also post it on the Evidence-Based Hair podcast as well. We're going to be reviewing 20 very interesting studies. 20 studies that are really changing what I do in the clinic, changing how we diagnose hair loss, changing how we treat hair loss. Really remarkable studies that I look forward to sharing with you. We're going to talk about 3 studies in oral minoxidil, 3 studies with Finasteride and dutasteride, 2 studies related to telogen effluvium or hair shedding, 4 in the area of alopecia areata, 3 with frontal fibrosing alopecia, which is a scarring alopecia, 2 with central centrifugal alopecia, another scarring alopecia, 1 with folliculitis decalvans, and 2 with lichen planopilaris, also scarring alopecias. We're going to start first with studies of oral minoxidil. I begin with a wonderful study which was published in JAMA Dermatology titled Oral Minoxidil versus Topical Minoxidil for Androgenetic Alopecia, a randomized trial by Penha and colleagues. This was really a very interesting study, and this study showed that oral minoxidil 5 milligrams and topical minoxidil 5% twice daily are fairly similar in their ability to promote an increase in terminal hair counts on the scalp in males after 24 weeks. And there was a hint, at least with clinical photographs, that the oral minoxidil might have been a bit better for the back or the crown, not for the front. But we'll dive into this very intriguing study. A study which gives us answers to how much better is oral minoxidil? There are some views in the world that it is dramatically better, 10, 50, 100 times better. We'll take a look at this really important study which gives us new perspective. So the purpose of this study was to compare the benefits of topical and oral minoxidil in treating males with androgenetic alopecia. Really nice study. Last author, Dr. Paulo Mueller-Ramos. So oral minoxidil, in case you don't know, was originally used as a blood pressure medication in the mid to late 1970s and 1980s. And it was used as a last resort. Several other medications are often tried first at that time, and if they were unsuccessful, oral minoxidil would be used. It wasn't an easy medication to use. Patients using oral minoxidil often had an increase in heart rate. They often had an increase in hair all over the body, including the scalp, as well as other side effects. And that led, of course, to the approval of topical minoxidil several years later. But oral minoxidil was approved for the treatment of hypertension or high blood pressure in 1979. The doses used for high blood pressure ranged 10 milligrams up to 40 milligrams, and even higher, sometimes 60, 80, and 100 milligrams. It became clear with the use of oral minoxidil that hair growth was an important effect of this blood pressure medication, and minoxidil became approved in 1988, first at 2% and then as 5%. There's been incredible interest in oral minoxidil for treating hair loss. This interest spans back 15 years or more. There's been several investigators in the world that have had an interest for a long time in oral minoxidil. But the worldwide interest in oral minoxidil spans about 5 or 6 years. But surprisingly, high-quality studies have only recently started to be done, most as retrospective and limited prospective studies. But high-quality randomized controlled trials had not really been done up until this Penha study. Up until this year, this study you see on the screen, the Penha study, was the study that we quoted about oral minoxidil. It was a small study. It was an open-label study. It was not randomized. And it suggested that oral minoxidil was wonderful. It was a prospective study in males age 24 to 59 with androgenetic alopecia. There was 30 males in the study. They received 5 milligrams once daily for 24 weeks. The key take-home message of that study was for the crown, or the back, which we call the vertex, 93% of users had moderately or greatly increased hair density with using 5 milligrams of oral minoxidil. What a wonderful result. For the front, the results weren't quite as good, but still pretty good. 73% of males had moderately or greatly increased hair density at 24 weeks by using 5 milligrams of oral minoxidil. And so that Penha study was a study that we quoted in the clinic. Patients asking, how well does it really work? Well, we don't really know, but there's one study which is small, 30 patients, which suggests that it works pretty good in the crown. And in fact, the Penha study suggested that no males did not benefit. In other words, everyone benefited somewhat. You either had a little bit of improvement or quite significant improvement. The type of study with the highest quality of evidence is the randomized controlled trial. And the Penha study is one of these randomized controlled trials. And the Penha study set out to compare oral minoxidil against topical minoxidil, to put the two side by side and ask the question, how do these compare? And so the authors from Brazil set out to compare the efficacy, safety, and tolerability of 5 milligrams of oral minoxidil against topical minoxidil, 5%, twice daily, for the treatment of androgenetic alopecia in males, a 24-week study. And it was a double-blind, placebo-controlled, randomized controlled trial. These are the studies that we hope to see when we're looking for the highest quality of evidence. Eligible men were those 18 to 55 with androgenetic alopecia, with Hamilton-Norwood 3V, 4V, or 5V, and they were randomized into two groups: oral minoxidil 5 milligrams and topical solution that was a placebo, or topical minoxidil 5% twice daily with oral pills that were a placebo. And so this was a very elegant study. Patients received either something to put on their scalp and pills, or the true pills as oral minoxidil and placebo solution. So everyone was eating something and putting something on their scalp. The something might have been a placebo in some cases, and the something was the real drug in other cases. But patients were blinded to what they were doing, and investigators were blinded as well. The primary outcome was the change in terminal hair density, the thick hairs in the vertex and frontal regions of the scalp. And a whole bunch of secondary assessments were part of the study as well. There were 90 participants that were enrolled. 68 ultimately completed the study. The mean age of patients was 37. 33 were in the oral minoxidil group and 35 were in the topical minoxidil group. Most patients had mild to moderate androgenetic alopecia. There were some dropouts in the study, but the proportion of dropouts was the same in the oral minoxidil group and the topical minoxidil group. So how well did the oral minoxidil and topical minoxidil groups compare? Let's take a look first at the frontal area. Well, very interestingly, when data for the frontal area was compared in terms of terminal hair count changes, there was no statistically significant difference in the ability of oral minoxidil and topical minoxidil to promote hair growth. They were fairly similar. They both led to an improvement in terminal hairs, but no statistically significant difference. What about the vertex area? Again, no statistically significant difference in the ability to promote hair growth in the vertex area. Both led to an improvement in hairs, but they were not statistically significantly different. That was for terminal hair density. For total hair density, the combination of terminal hairs and vellus hairs, no statistically significant difference for the vertex, no statistically significant difference for the frontal scalp. So really important data, suggesting that, at least in this study, 33 patients in one group, 35 in the other, that we cannot conclude here that oral minoxidil has clear superiority. Not what the data is showing. What do clinicians think when they examine photos? Well, according to photographic assessments of 3 blinded dermatologists, they don't know who's receiving oral minoxidil and they don't know who's receiving topical minoxidil. Blinded dermatologists looking at photographs felt that oral minoxidil was a little bit better for treating androgenetic alopecia on the vertex, but it wasn't better for treating the frontal area. And so when we look at the global assessments of photography for the vertex, you can see that 21% receiving oral minoxidil had a great improvement compared to 6% using topical minoxidil for the vertex. What were the side effects? Well, I really like this graph. We're going to be talking today, this chart, we're going to be talking today about side effects of oral minoxidil a few times. And one thing which doesn't get quite as much appreciation as it really needs to is oral minoxidil is a wonderful medication, but it certainly has side effects. And few other medications in a busy practice really cause the phone to ring off the hook and emails to come in as frequently as oral minoxidil side effects. So oral minoxidil caused hypertrichosis in 49% of those in the oral minoxidil group, 25% in the topical minoxidil, and there was a statistically significant difference. So oral minoxidil is more likely to cause hypertrichosis. It was more likely to cause headaches, 14% in the oral minoxidil group. Scalp eczema or redness and flaking was more common in the topical minoxidil group. This was a topical minoxidil solution, 5% twice daily, and we know that the solution has a tendency to cause eczema in users. The other side effects didn't seem to differ. So this is a really important study and one for the history books. This will undoubtedly be a study that is quoted for quite some time to come. It is one of the first well-done comparative studies of low-dose oral minoxidil in androgenetic alopecia. And these authors, Dr. Paulo Mueller-Ramos, are experts in these well-designed randomized controlled trials of oral minoxidil in androgenetic alopecia. They performed some wonderful studies 4 years ago, looking at how 1 milligram of oral minoxidil stacks up to 5% minoxidil in women, showing that those two were comparable in females. And here, another wonderful randomized controlled trials. These are the types of studies we need to really guide us in how to move forward. And so overall, this study showed that oral minoxidil may just have a slight hint that it's superior to topical minoxidil for the crown, at least in photographic changes, but not in its ability to promote changes in terminal hair density. So I really like this study. It certainly gives us some guidance that maybe, just maybe, treating the crown with oral minoxidil might be slightly better, but it comes at a risk. It comes at a risk of side effects, of hypertrichosis. And I think this study will really be important to fuel additional studies in understanding the differences between these two medications. Hypertrichosis and headaches were more prevalent in the oral minoxidil group, and clearly side effects of oral minoxidil need to be carefully reviewed with patients, as these are long-term drugs, not just over 24 weeks, but 24 years, 40 years, depending on how long one wants to keep their hair. So a really important study that reminds us of the importance of randomized controlled trials. This study really gives perspective and shows inferior results to the Penha study. But the two designs, of course, are very different. One open label, the Penha 2020 study, here a randomized controlled trial. In the Penha study, everybody improved. In the Penha study here, a third of patients received no significant improvement at all, or even worsened on oral minoxidil. So I think that's important perspective, that a helpful drug, a drug with side effects that need to be counseled, and a drug that doesn't help everyone. So the debate's far from over exactly how best to use oral minoxidil. These studies are very important, and I congratulate these authors for this study and their wonderful work in this area in general. And as I mentioned, these authors have performed very nice studies in the past comparing oral minoxidil to topical minoxidil in women, and here topical minoxidil to oral minoxidil in males. So congratulations to these authors. This is such an important study for us all to be aware of. We move on to another nice study of oral minoxidil, this time a study looking at a side effect of fluid retention. The title here, Characterizing Low-Dose Oral Minoxidil-Induced Peripheral Edema in Alopecia Patients, published in the Journal of the American Academy of Dermatology by Salas and colleagues. This study showed very nicely that about 8.8% of users of low-dose oral minoxidil had fluid retention, and we'll take a look at some of the risk factors together. When patients stopped, fluid retention went away quite quickly in most users. If patients chose to continue, some resolved their fluid retention despite continuing, but a large proportion did not. But before we move together into the world of oral minoxidil side effects and the world of oral minoxidil, it is critically important that everyone understands two fundamental papers in the area of oral minoxidil. And these are studies by Sanabria and colleagues, published in the Journal of the American Academy of Dermatology in 2021, and in the same issue, a study by Dr. Vanyo and colleagues. These studies looked at minoxidil side effects, oral minoxidil side effects. The Vanyo study, a study of 1,404 patients. The Sanabria study, a study of 435 patients. The Vanyo study was conducted differently than the Sanabria study. The Vanyo study asked clinicians to fill out information regarding their patients, their risk of some of these side effects, and how common they were. The Sanabria study was a unique study where the investigators picked up the phone and called patients and asked them, how commonly are you getting these side effects? They ring them on the phone and ask, did you take oral minoxidil? Yes. Did you get hair growth on the face? Yes or no? Did you get headaches? Yes or no? Did you get pedal edema? Yes or no? So a very detailed study in that regard. And so the numbers for these side effects are slightly different. But you can see that oral minoxidil side effects include hypertrichosis and headaches, like we saw in the Penha study, pedal edema, palpitations, periorbital edema. These are really important to know about, as these are side effects that we need to counsel patients about. If you're starting oral minoxidil, I want you to know about the chance of hair growth on the face, palpitations, swelling in the feet, swelling around the eyes. 15% in the Vanyo study got hypertrichosis, 54% in the Sanabria study. Headaches in anywhere from 0.4 to 10%. Pedal edema in 1.3% up to 9%, with the Sanabria study showing that females may be more predisposed to getting swelling in the feet. Palpitations in 1 to 4%, and swelling around the eyes in up to 1%. So the purpose of this Salas study was to understand the specific features and risk factors associated with low-dose oral minoxidil-induced edema. it was a retrospective study of hair loss patients treated with oral minoxidil over the period 2023 to 2024. And patients were included in this study if they had a diagnosis of hair loss. They were on oral minoxidil for at least 1 month, and they had at least 2 visits to the clinician for evaluation of their treatment side effects. So a nice study with 250 patients. The majority of patients here, 78%, were female. And this will be important as we go about thinking about this study because, as we saw in the Sanabria study, females may be slightly more predisposed to develop fluid retention. And so if you have a study with more females, maybe you might have higher numbers. 8.8% of patients in this study had fluid retention. I think that's really important. There were 20 adults in this study, 2 children. And the sites of fluid retention were threefold: the bilateral legs and feet, the lower extremity, the face, and the hands, in that order. I think that's really important. It just reminds us that, side effects aren't limited just to the feet, that we're retaining fluid in other areas, and they show up around the eyes and in the hands. Most common presentation was pitting edema, and that typically developed about 3 months after starting low-dose oral minoxidil, consistent with other studies. The fluid retention doesn't happen the next day after starting, doesn't happen the next week, and sometimes not even the next month. It can happen within the first 3 months. How did patients treat their edema if they had fluid retention? Well, the strategies included reducing the dose, stopping it, and adding a diuretic. These types of treatments led to a resolution of edema in about half of patients within 1 to 2 weeks, but not everybody. What happens if you chose not to stop? Many patients say, I'm getting some very nice results. I have a little bit of swelling around my face, happens in the morning, goes away in the evening, swelling around my feet. What happens if I don't stop? Well, this very nice study reminds us that just under 50% had spontaneous resolution, even if they chose to continue, 3 of the 7. But many patients continued with their edema. Who's most likely to get edema? Well, these were the risk factors. Patients with a prior history of edema, patients with cardiovascular disease, patients with prior kidney transplant, and prednisone use, here for polymyalgia rheumatica. Consistent with some of the prior literature that heart disease, kidney disease, these are risk factors for peripheral edema. So overall, the incidence of swelling with oral minoxidil was 8.8%. And there was an association between the dose and the risk for edema. This study showed that edema usually resolves very quickly in most patients if they choose to stop the medication. But what I particularly liked about this study is it reminds us that there's 3 sites to warn about. And that includes the lower extremity, the face, and the third area is the hands. And when I think of edema, I think of the 3 syllables in edema. And that reminds me that there are 3 places to warn patients about. And often when we counsel patients about fluid retention, we feel that we want to stop at, you might get swelling in the feet. But really what we want to say is, you might get swelling in the feet and hands and face. The 3 syllables of edema reminds us that there's 3 body sites to counsel patients about. And sometimes patients even get a 4th site, and that's just generalized edema, a generalized increase in body weight with no clear etiology, and that might be fluid retention in a more widespread distribution. But certainly these are the 3 important sites to counsel patients about. So a really nice study by Salas et al. I congratulate these authors for such a nice study, which really puts us that much bit forward with understanding the risk factors for minoxidil-related edema, some more information we can counsel patients about how likely it is for edema to go away if we stop, likely for edema to go away if we continue. I think this will fuel additional studies in really understanding how best to use oral minoxidil and how best to counsel and take care of our patients. We move on to another nice study of oral minoxidil, our third in this category by Dr. Jimenez. Last author, Dr. Vanyo. Safety of low-dose oral minoxidil in patients with hypertension and arrhythmia. A multicenter study of 264 patients. A multicenter study spanning Brazil and Spain. This study addresses the question, if the patient in your office today has high blood pressure, can you safely use oral minoxidil for androgenetic alopecia or not? What about if they have arrhythmia? Well, this study really boldly explores this question. A study that really had not been done before, and a study which shows us that for the vast majority of patients, provided they're stable and provided they're on 1 or 2 blood pressure medications and don't have any other risk factors for serious cardiovascular disease, that the answer may be yes. But the study concludes by reminding us that we have colleagues in cardiology, and cardiologists were included on this paper. We have colleagues in cardiology that can assist us in the event a patient has a complex cardiac history to help guide us whether these tiny doses of oral minoxidil are safe or not. So the purpose of this study was to evaluate the safety of oral minoxidil in patients with high blood pressure and arrhythmia, 2 distinct groups here. So Jimenez and colleagues set out to evaluate the safety of oral minoxidil. It was a retrospective study, and patients that were included in this study had received oral minoxidil for at least 1 month at 5 centers in Brazil and Spain. 254 patients in this study. 176 were women, 78 were men. Median age was around 57 years. And there was 254 patients, but some patients had received different doses of oral minoxidil in their treatment time course. And so there were 382 doses that could be compared. Patients had high blood pressure, and patients received anywhere from 0 to 5 high blood pressure drugs. The mean number of drugs was 1.45. So some patients received 0, some 1, 2, 3, 4, 5. The most frequent drug class was the angiotensin receptor 2 blockers in about half of patients with high blood pressure. But you can see on this list a whole range of different blood pressure medications were used, and some on 2 and 3 and 4 and 5. The mean dose of oral minoxidil was 1.59 milligrams, and the mean duration of treatment was around 11 months, ranging from 1 to 51 months. This was a study that included patients with many types of hair loss. Not only androgenetic alopecia, that was certainly the most common, but patients also included frontal fibrosing alopecia, telogen effluvium, and various types of scarring alopecia, and a small proportion with alopecia areata. All in all, side effects were detected in 6.8% of cases. These included lightheadedness in 3%, fluid retention in 3%, malaise and tachycardia in 1%, and headaches in about 0.5% of users. Oral minoxidil needed to be stopped in 1.5% of cases. I think that's really important. I think when we start any medication, we want to have some understanding of what percent of patients really need to stop. And here, 1.5% of patients. As we'll see later on tonight with the JAK inhibitor ritlecitinib, about 10% of patients need to stop the drug. That's really helpful up front to get that sense of the proportion of patients that are going to be needing to stop the drug you're prescribing. How well was oral minoxidil tolerated? Well, most side effects improved with dose adjustment or stopping the drug. So that's really important. These side effects were not permanent, and there were no life-threatening side effects that were observed. Certainly really important in any group, but important in this group with risk factors for disease. Patients with high blood pressure have a risk factor for cardiovascular disease. Patients with arrhythmia have significant risk factors for further cardiovascular issues. So what were the factors that predisposed patients to have to stop their medication? Well, these authors showed that there were several risk factors. Patients who received 3 or more antihypertensive drugs, and those who received a specific antihypertensive drug called doxazosin, which is an alpha-adrenergic blocker, were more likely to need to stop the drug. In fact, patients who received 3 or more drugs had a higher risk of developing more than one side effect, had a higher risk of developing lightheadedness, general malaise, in addition to needing to stop their oral minoxidil. And prior treatment with doxazosin was associated not only with a higher risk of needing to stop oral minoxidil, but a higher risk of experiencing lightheadedness and malaise and fluid retention and needing to adjust the dose. And so when we're working with patients with this particular risk factor, patients with high blood pressure, we really want to respect patients with 3 or more drugs and potentially patients with more and more hypertensive medications on board and pay attention to that drug doxazosin. These are risk factors for needing to stop and risk factors for side effects. So the authors very nicely commented on what are the differences in risk factors you might expect in using oral minoxidil in healthy patients in the general population compared to side effect incidence in patients with high blood pressure. Well, to look at this question, they looked back at their 2021 study, the Vanyo study of 1,404 patients, and looked at some of these side effects and then compared it to this study. And what they found is that patients with high blood pressure, here in the Jimenez study, were a little bit more likely to experience lightheadedness compared to the general population, 3.1% versus 1.7%, and patients with high blood pressure were a little more likely to experience fluid retention, 2.6% versus 1.5% back in the big 2021 Vanyo study. So that's blood pressure. What about arrhythmias? So these authors not only looked at the safety in patients with high blood pressure, but the safety in patients with arrhythmia. And I congratulate these authors for looking at this group. Really an important study. It is so easy to say when a patient has an arrhythmia that, you know what, oral minoxidil is off the list. But sometimes you're faced with patients that have used a lot of medications. They've used topical minoxidil, they've used finasteride or are using finasteride, they are using or have used topical finasteride, laser, PRP, microneedling, exosomes, hair transplantation, and we're running out of options. And the question becomes, there's oral minoxidil on the list. Is this even a point of discussion in a patient with an arrhythmia? So these authors looked at the safety of oral minoxidil in patients with arrhythmia. 9 patients had a history of arrhythmia, including 3 with supraventricular extrasystole, 1 with atrial fibrillation, 1 with sinus tachycardia, 1 with cardiac syncope, and 3 with an unknown arrhythmia. 4 of them were under medical treatment with beta blockers or amiodarone. 2 patients had a prior cardiac ablation, 1 had a pacemaker, 2 weren't receiving any treatment, and 1 had a mechanical aortic valve. Systemic side effects were observed in only 1 patient. This was a patient with supraventricular extrasystoles who was treated with carvedilol, and he developed periorbital and pedal edema with 1 milligram. And this improved with bringing the dose down to 0.25 milligram. And no other patients had palpitations, worsening of their arrhythmia, or any cardiac side effect that needed dose adjustment. So really important to give us this perspective. And these authors included a cardiologist on this paper. And so, really a nice study which addresses this question that has not been addressed in the literature regarding the safety of oral minoxidil in patients with not only hypertension but arrhythmia. So it's the first of its kind, and we need this data. This data is so important. Why is it so important? Well, up to 34% of the world has high blood pressure. And so we're going to have numerous patients that come through the door with high blood pressure. And we need to have an understanding whether oral minoxidil is something that we can initiate a discussion with or not. And the authors found that for the most part, side effects were similar to patients without hypertension. But there were two side effects that were more common, and that was fluid retention and lightheadedness. So we have to counsel, of course, about all the side effects, but be aware of that slight increased risk of developing those two side effects. But fortunately, when patients reduced their dose or stopped, these side effects went away. Hypertrichosis was quite common, but improved again with reducing the dose. But about 7% of patients had lightheadedness. And this was the most common reason for patients needing to stop. What I also liked about this paper by Jimenez is it concludes with some nice recommendations on the use of oral minoxidil in this group. And one comment was starting the medication at bedtime may help reduce side effects. Being aware of the populations with 3 or more drugs on board, 3 or more antihypertensive drugs on board. But reminding us that we can always do an EKG or an electrocardiogram. We can always refer patients to a cardiologist if we're not sure. But for a large percentage of patients that are quite stable on one blood pressure medication, we can often start these medications quite safely. And the authors remind us that in a very balanced view, this is not a medication for everyone. Patients should not be starting oral minoxidil if they have significant cardiovascular risk, especially if they're not under care of a cardiologist with those risk factors. Patients with prior heart attacks, heart failure, valvular disease, pericardial disease, kidney disease, these are patients that are not good candidates for oral minoxidil. And a very important message of this paper is if you're not sure, refer. If you're not sure about the significance of a patient's cardiovascular risk factor, we have our colleagues in cardiology that are there to assist us whether this is a good idea or not, and whether we should be prescribing this medication or not. And so I congratulate these authors for a really important study which pushes us that much bit forward in understanding the use of these medications in patients with hypertension and arrhythmia. So we move from oral minoxidil to studies of finasteride and dutasteride. These are the so-called 5-alpha reductase inhibitors, which are used for a wide variety of hair loss conditions. Used, of course, in androgenetic alopecia in males, finasteride being approved at 1 milligram for males, but also used off-label in other conditions like frontal fibrosing alopecia, androgenetic alopecia in females, fibrosing alopecia in a pattern distribution, as well as a few others. So we begin by a very nice study by Dr. Moreno and colleagues. Last author, Dr. Vagno, the impact of finasteride and dutasteride in beard thickness in men with androgenetic alopecia. A really nice study which addresses the question, do males using finasteride and dutasteride who have beards need to worry that finasteride and dutasteride may impact beard thickness? The answer to this study is probably not. A very large study, in fact, showing that the overwhelming majority of males with beards have no change in their density. So beard density is really important, and different eras throughout history place different emphasis on beards, and throughout the world right now, beards are certainly very much important. And in certain regions of the world, beards are extremely important. And I'm often asked if finasteride and dutasteride can inhibit beard growth, a question that I get surprisingly high number of times. Typically a male, 18 or 19 to 30, asking whether the use of finasteride and dutasteride can impact their ability to grow a full beard. And it's a really important question and a reasonable question. Studies have shown that sex steroids like testosterone, DHT, and other adrenal androgens and estradiol play a role in the development of secondary sexual characteristics in males. And those secondary sexual characteristics include beard growth, chest hair. It can take until age 25 and even 30 until maximal beard growth takes place. It's really interesting because maximum adult testosterone is usually setting in the teenage years, around age 15. But it can take much longer before full beard growth takes place. And so the purpose of this study was to determine if the use of 5-alpha reductase inhibitors is associated with a decreased beard thickness in males. So the authors retrospectively compared clinical photographs of males younger than 35 who received these drugs for at least 12 months. The inclusion criteria included having an established beard that was similar to the density in one's father, so an established full beard density. Patients were asked to trim their beard at follow-up visits to the same density as when they came the first time, and beard thickness was evaluated via photography. 453 patients in this study, so a nice study, a large study. Mean age was 25 years. Finasteride was prescribed to 22% of males, and dutasteride was prescribed to 78% of males. Here's the key point in the study. 96.9% of males had no change in their beard thickness with use of finasteride or dutasteride. 1.1% had a decreased beard thickness, and 1.9% had an increased beard thickness. So the overwhelming majority have no change. Really important. And of course, the males experiencing decreased beard thickness doesn't necessarily implicate finasteride or dutasteride. If one has a telogen effluvium and has hair shedding from a flu or some infection or some other issue causing hair shedding, then not only can scalp hair, but sometimes beard hair density can decrease. If one has infection in the beard or significant seborrheic dermatitis, psoriasis, other issues that cause inflammatory change, sometimes patients can experience decreased density. But the overwhelming conclusion here is that finasteride and dutasteride don't impact beard thickness in males with established beards. And the authors point out quite nicely that these drugs, these 5-alpha reductase inhibitors, are not pure antiandrogens. They block DHT, but they don't decrease serum testosterone levels. Sometimes they even increase it. And on account of that, they don't negatively impact testosterone, which may allow it to remain in the blood and facilitate normal beard growth. So a really important study which gives us guidance in how we assist males with beards and understanding the impact of finasteride and dutasteride potentially on their beards. And a really important study which will impact many, many males in my practice who are interested to know about the safety of finasteride and dutasteride, specifically on beard hair growth. So I congratulate these authors on such a unique study, a study which is so very much important and needed. We move on to another study, in fact, 2 back-to-back studies, all asking a very similar question, and that is, do women using finasteride and dutasteride have an increased risk of breast cancer? These 2 studies show us that no, they do not. They do not appear to have an increased risk of breast cancer, and some other gynecologic cancers are not increased as well. We begin by a study by Chen and colleagues, last author Dr. Marianne Senna from Boston, titled 5-alpha reductase inhibitor exposure for dermatologic conditions does not increase the risk of female breast or gynecologic cancers, a population-based propensity score-matched cohort study, published in the Journal of the European Academy of Dermatology. This is such an important study. The question of whether finasteride and dutasteride increase the risk of breast cancer has been with us for 25 years. And some of the logic behind this stems from a number of reasons. First, some very early studies in males suggested that maybe finasteride could increase breast cancer in males. Later studies suggested that no, it doesn't seem to increase the risk in males. As well as studies showing that maybe finasteride and dutasteride can increase serum estradiol levels slightly, and if women are predisposed to estrogen-dependent cancers, that perhaps this increased serum estradiol, estrogen, can increase the risk of breast cancer. A growing body of data over the last few years has suggested that maybe that's not correct. We have 3 commonly used antiandrogens, spironolactone, dutasteride, finasteride, as well as others like bicalutamide. For spironolactone, studies have shown no increased risk of breast cancer in women. There have been 3 NICE studies, which were summarized in a meta-analysis in 2022 by Balmaretti, published in the journal JAMA Dermatology, and those studies showed no increased risk of breast cancer with the use of spironolactone. In fact, no increased risk of many cancers. But data on finasteride and dutasteride were not present until now. The theory, as I mentioned, has been that finasteride and dutasteride increased estrogen. And in women with a predisposition to estradiol and estrogen-induced tumors, this may be a problem. Well, this very nice study in 2019 shows us that spironolactone increases estrogen by up to 26%. 26% of individuals have an increased estrogen. And spironolactone is not associated with an increased risk of breast cancer. Finasteride increases estrogen. 34% of patients have increased estrogen. And so those levels of estrogen increases are comparable. And so if some users of spironolactone have increased estrogen, and spironolactone does not seem to be associated with breast cancer, then the fact that finasteride increases estrogen should not necessarily concern us. Of course, good studies need to be done. And despite those early studies, one mainly, showing an increased risk of breast cancer in males, most recent studies in males have suggested that males don't have an increased risk of breast cancer with finasteride, dutasteride. Males can develop breast cancer. It's less common than in females, but they can. And so those models of male breast cancer are important. They give us some understanding of the effects of this drug on breast tissue. But the purpose of this study by Chen was to determine if the use of these class of drugs, finasteride, dutasteride, the 5-alpha reductase inhibitors, are associated with an increased risk of breast cancer. They used this TriNetX database, and they included patients in the database that were over 18 and were diagnosed with several dermatologic conditions: female pattern hair loss, acne, hirsutism, lichen planopilaris. And they matched those patients 1-to-1 with control patients. And the controls had similar characteristics but did not receive finasteride or dutasteride. They found 1.7 million eligible patients, and 13,853 were treated with 5-alpha reductase inhibitors. Here's the key point of the study. Among finasteride and dutasteride users, 1.5% developed breast cancer. Amongst those in the study that never used finasteride and dutasteride, 2.2% developed breast cancer. The mean follow-up was 4 years. And so compared to those that never used these drugs, patients that were prescribed these drugs, finasteride and dutasteride, did not have an increased risk of cancer. The risk of breast cancer was not increased. The risk of uterine cancer was not increased. The risk of ovarian cancer was not increased. The risk of cervical cancer was not increased. These confidence intervals crossed 1. So I think this is really important. And I congratulate Chen and colleagues for this very nice study, which gives us new perspective about the risk of these drugs and places it very similarly to the risk we understand for spironolactone. And that is, these anti-androgens are not coming with a significant increased risk of breast cancer, nor other cancers as well. Coincidentally, another study in the Archives of Dermatologic Research in November 2024 looked at the same question. And that is, do these drugs increase the risk of breast cancer? They used the same database, TriNetX database, looking at patients using finasteride and dutasteride and comparing the risk of cancer in those that did not. They matched them 1-to-1. They found 5,156 females using 5-alpha reductase inhibitors and compared them to 5,156 matched controls. There was no difference in the risk of ovarian cancer or endometrial cancer. There was no difference in breast cancer risk after 1 or 5 years. And what was interesting about this study is the authors found that their calculated lifetime risk of breast cancer was decreased with the use of finasteride and dutasteride. An intriguing observation. And the lifetime risk of cancer with 5-alpha reductase inhibitors is showing in this graph, this chart, with breast cancer lifetime risk being reduced by the use of finasteride or dutasteride. Confidence interval under 1, with no change in endometrial cancer and no change in ovarian cancer, suggesting that there's no evidence that finasteride and dutasteride increase the risk of endometrial or ovarian cancer. So really important data, really encouraging data, that finasteride and dutasteride in women in this group do not appear to increase the risk of endometrial, ovarian, breast cancer, and may even reduce the risk of breast cancer. Of course, we have to be careful about that study, observation, but certainly no increased risk. This is really important. I think it really guides that, at least in women of average risk, we have no evidence that these drugs increase the risk of breast cancer. What we don't know is in women of high risk, whether this data applies. And so there are risk calculators online which allow one to calculate a person's risk of breast cancer. And I think caution is still needed in women of high risk for breast cancer. Whether these results apply, we don't know. But in women of average risk, we have no reason to believe these drugs increase the risk of breast cancer, nor spironolactone. So congratulations to these authors for really important data, which gives us an important framework to guide our patients in these challenging decisions. Finasteride and dutasteride are not FDA approved for women with hair loss of any kind, so they are off-label treatments. And these decisions on how to use them, what to use, are really important. Really important because these drugs can be helpful for some women with androgenetic hair loss. And And as we reviewed last year, meta-analyses by Gupta showed that, when you look at these sucra ranking scores, finasteride may be a very useful option for androgenetic alopecia in women. And there are important concerns about side effects. It cannot be used in women in childbearing age. It can cause harm to a fetus. There are other side effects. But as we counsel patients about breast cancer, this is an important study which gives us new perspective. So thank you. We move now to some nice studies of telogen effluvium or hair shedding, beginning first with a study by Gottfried and colleagues looking at the risk of telogen effluvium with the GLP-1 GIP agonists. You know these as tirzepatide, Mounjaro, and semaglutide, Ozempic, and other names they go by as well, titled Alopecia Associated with the Use of Semaglutide and Tirzepatide, a Disproportionality Analysis Using the FDA Adverse Events Reporting System, from 2022 to 2023. The main message of this study was that there is a signal that the use of this class of medications is associated with hair loss. And I think this is a really important study which fuels us to conduct further studies in the true incidence of hair loss with these drugs, as well as more of an understanding of the mechanisms and an understanding what we can do. So there's a growing body of data that the use of these drugs, particularly semaglutide and tirzepatide, can cause hair loss. And in fact, in 2022, the FDA flagged hair loss as an adverse event that needs further study. And the FDA has said that they're evaluating the need for further regulatory action. This is a big deal. It's always a big deal when the FDA says, we're paying attention to this side effect. And so we know that the FDA is monitoring this, and the FDA is, at some point, going to come out with some further guidance on the importance of this. Sometimes that means that the FDA says a product monograph has to include hair loss as a warning. Sometimes it means that other study needs to be done. But when the FDA says they're monitoring, it means that they're going to come back to the public and come back to the company with some further information on what they feel is appropriate. So the purpose of this study by Gottfried and colleagues was to determine if these GLP-1 GIP agonists are linked to hair loss in a more formal study. So they used a big database called the FDA Adverse Event Reporting Database to look at reports of hair loss with these drugs. If you and I want to know if these drugs cause hair loss, one way is to ask people on these drugs to fill out your survey. Did you use semaglutide? Yes? Well, fill out my survey. Did you get hair loss? Yes or no? How much hair loss? When did it occur? The other way is to look at big databases where people with side effects put their data, and to look at that data and try to analyze it in a meaningful way. And that's what these disproportionality analyses with these big databases seek to do. You look at the database and pull out all the patients reporting side effects with these drugs like hair loss and compare their side effect profiles to patients with side effects from other drugs. And so they performed what's called disproportionality analysis. Disproportionality analysis is a statistical technique where you try to compare the reports of side effects from the drug in question to reports of side effects from other drugs to get a sense of how likely is it that the drug in question is truly causing hair loss. And what you come up with disproportionality analysis is an ROR or a reporting odds ratio. And so what they found by looking in this database is that reports with this drug class were made from consumers and clinicians. 84% of the reports that were entered into this database came from patients, and 16% came from healthcare professionals. That's important, and it's important to understand that if you have a side effect from a drug and you're a clinician, you can report it on your patient's behalf to these databases. But if you're a patient, you can report yourself into this database. So both are mechanisms by which side effects can be tallied, accumulated. The authors found 199 hair loss reports linked to semaglutide, Ozempic, and others, and 179 related to tirzepatide, which includes Mounjaro and others. There were fewer reports for others like liraglutide, exenatide, lixisenatide had no reports at all. But semaglutide and tirzepatide were the most commonly reported GLP-1 GIP agonists that had entries in the FDA adverse event database. And when the authors Godfrey et al. Calculated the ROR, they found statistically significant RORs for semaglutide and tirzepatide. And what this means is there's a signal. There's a signal that these drugs may be associated with hair loss, and that we need more studies to really further evaluate and quantify these side effects. So the study is a really important study. It highlights the potential of these drugs to be causing hair loss and the importance of further study. And the authors remind us that, this is important. The clinical trials of semaglutide, tirzepatide, and many of these GLP-1 GIP agonists don't include hair loss. And so these are important post-marketing side effects and really important for us to continue to study. We'll be hearing more and more about hair loss from GLP-1 GIP agonists. These drugs are hugely popular around the world. Studies have shown in the United States, 1 out of 8 adults have used this class of medications. And these, of course, are used originally for diabetes, but their mechanism of action has been shown to be helpful in weight loss. And 1 in 8 adults have used these medications, and currently 15 million users are currently using these class of medications in the United States. So hugely important. So we owe it to 15 million individuals today to address the question, how likely are you to get hair loss? Which drugs are most likely to cause hair loss? And does this information influence your decision on using this class of medications? What can we do if you do get hair loss is an equally important question. We'll be hearing a lot more about GLP-1 GIP agonist-induced hair loss in the years to come, and I thank the authors for this very nice study. We move on to another study in telogen effluvium, our final study in telogen effluvium, titled Postpartum Hair Loss is Associated with Anxiety. A study in our gynecology colleagues' literature, published in the Journal of Obstetrics Gynecology Research. I really like this study. Postpartum hair loss is, of course, extremely common worldwide. Studies suggest that 90% of women lose hair postpartum. And there's a tremendous amount of myths online about postpartum hair loss, and a tremendous amount of false information and false marketing of products that hope to work. But this area really hasn't received enough attention. And postpartum hair loss is a physiologic effluvium. Hair often improves in many women in pregnancy, and especially if there's some baseline androgenetic alopecia, and the proportion of hairs in telogen decrease dramatically in pregnancy, and then there's a return to normal after pregnancy. And so for the most part, it's thought that we cannot stop a postpartum telogen effluvium. It is a normal physiologic process. But the question arises, what is the impact of the effluvium? And the bigger question is, what can we do to help women cope with postpartum effluvium? And what can we do to actually change those statistics in terms of the incidence of effluvium? But this very nice study looks at anxiety postpartum and shows us that patients with severe shedding after giving birth are the most likely to experience anxiety. And this is an important risk factor for anxiety in the postpartum period. And intensive hair shedding, women whose birth is their first birth, and women with poor sleep and very high degrees of insomnia are the three most common risk factors to give postpartum anxiety. So postpartum hair loss often occurs around 3 months postpartum. It can start 2 months, it can start 5 months, and it often lasts 3 to 8 months. But generally by year 1, it has largely resolved. And there have been few good studies which have looked at the anxiety associated with postpartum hair loss. And I really like this study. The authors set out to examine the relationship between postpartum hair loss and psychological symptoms. To do this, a questionnaire was given to women 10 to 18 months after delivery. Baseline characteristics were collected regarding pregnancy, whether this was the first pregnancy, second pregnancy, the type of delivery, and other factors in their life. And a variety of psychological scales were administered, including anxiety and depression scales, and even a specific sleep scale evaluating insomnia. There were 300 surveys that were administered. 60% of patients rated their hair loss as quite a lot or very much. So 60% of patients had a lot of hair loss. In 46.5%, that was quite a lot. But in 14.5% of patients, it was rated as very much. Hair loss started, on average, around 2.9 months after delivery. It peaked at 5 months on average, and it resolved on average at 8 months. Consistent with other data, but very nice data which allows us to capture that important information. About a third of women met the criteria for postpartum depression and anxiety in this particular study. Women with very much hair loss, so women with really significant postpartum shedding, were more likely to be anxious than women with no shedding. And this was based on these carefully conducted anxiety scales. The authors evaluated 7 factors to understand what factors are really associated with developing anxiety in this postpartum period. And they used a multi-regression analysis model, and they found that 3 factors are independently associated with anxiety. Women with a first-time delivery, women with significant postpartum hair loss, and women who aren't sleeping. High insomnia scores. So I really like this study. It's really a unique study, one of its kind, which shows these independent factors with anxiety, with intense hair loss being one of them. And further research is needed to understand how best to help these women cope in the postpartum. What are factors that we can predict during delivery or even before delivery, which could predict women with severe anxiety? And how can we help these patients cope better? And a bigger question, of course, is what can we do mechanistically as we understand the molecular machinery that guides the hair through these cycles? What can we do to influence telogen effluvium? Right now, surprisingly, there's not a lot that we can do. And of course, that doesn't sit well with anybody. We want to do something. We want to help people. But most of the things that we think help don't help. Most of the time, the effluvium resolves on its own because it was going to resolve on its own, and it didn't resolve because of the oil in the serum in the topical thing we used, or the topical product we used, or the supplement. It resolved because it was going to resolve. But I think as we understand the machinery over time, a bigger question comes, is there anything we can do that influences how these hair follicles behave? We don't have that information yet, but clearly an important area of research, and this area of postpartum shedding in general, such an important area that affects so many women each and every year. And I think there's much more we need to understand, but this study by Hirose really pushes us forward in understanding postpartum telogen effluvium. So we move now to a study of alopecia areata. Alopecia areata is an autoimmune disease that affects up to 2% of the population. Patients often develop hair loss in circles or patches, but some people can develop quite profound hair loss all over the scalp, which we call totalis, or all over the body, which we call universalis. And alopecia areata can affect children, it can affect adults, men and women. It can have a profound psychological effect. We categorize alopecia many ways, but one way is based on severity, with severe hair loss being the loss of 50% or more scalp hair loss, and mild to moderate being less than 50%. There's many treatments for alopecia areata. Traditional treatments have focused on chasing away the inflammation that is thought to be an important causative factor, with agents like topical steroids, steroid injections, immunosuppressants like methotrexate, JAK inhibitors, cyclosporin, sulfasalazine, and other immunomodulating medications like difenciprone, squaric acid. Dupilumab is a new class of medications that are approved for atopic dermatitis or eczema, are approved for other issues as well, including asthma. These are medications which particularly affect pathways related to allergy. And we know allergy pathways are relevant in alopecia areata. We use allergy medications in alopecia areata like cetirizine, fexofenadine, these antihistamines. And dupilumab, which goes by the trade name Dupixent, is approved for eczema in very young ages. So it's been studied in children. And the question becomes, can we use Dupixent and dupilumab in children with alopecia areata? Well, one of the challenges in using Dupixent in alopecia areata is that some studies show that dupilumab can cause alopecia areata. And some studies show it can treat alopecia areata. So what a bizarre conundrum, where you have a drug that can help a disease, but be careful because it can cause it too. So this study set out to look at the use of dupilumab in a small group of patients with alopecia areata in the pediatric population, and showed very nicely that this drug could help pediatric patients who had atopic dermatitis and alopecia areata, both. And that's what's important to focus on this particular study, is that these patients have what I call AAAD, alopecia areata and atopic dermatitis. So this is a very unique patient population, and the key is to recognize that group with dual medical conditions, alopecia areata and atopic dermatitis. And so the purpose of this study was really to understand the efficacy of dupilumab in these particular patients. And they performed a retrospective study of 20 children aged 5 to 16 with a mean age of 11 years. And patients here had AAAD, alopecia areata and atopic dermatitis. So these weren't children with alopecia areata only. These are patients with alopecia areata and atopic dermatitis. And remember, dupilumab is approved for atopic dermatitis down to very young ages. Atopic dermatitis also goes by the name eczema, very common condition in the general population. Atopic dermatitis affects many children, particularly common in alopecia areata. In fact, one of the more common medical comorbidities in alopecia areata. So there's going to be a whole number of patients with alopecia areata that say, oh, by the way, I have atopic dermatitis as well. When you see that alopecia areata and atopic dermatitis phenotype, signals have to go off in the back of your mind, because this signals a very special group of patients with a very special immune profile. And patients with AAD are candidates for dupilumab. They're candidates for JAK inhibitors. They're candidates for antihistamines. They're candidates for the traditional agents as well, like oral steroids, prednisone, topical steroids, methotrexate, cyclosporin. But here we're focused on dupilumab. Very nice, studied by David and colleagues. The severity of alopecia was measured by the SALT score. The SALT score is a means of assessing severity. A SALT of 100 means 100% loss. A SALT of 0 means 0% loss. A SALT of 1 means 1% loss. And so they used the SALT score to evaluate hair loss in these 20 patients. They conducted evaluations as they went along at 12-week intervals over this fairly long study, 72 weeks or longer. So what were the results? Well, the very nice results here showed that the SALT score dropped from a mean of 54 at baseline to 20.4 at 48 weeks, to 2.2 by 72 weeks. And remember, as we're going down, down, down on the SALT score, it means that more and more and more hair growth is occurring. And 86% of participants achieved at least a 30% improvement in their SALT score at week 48. But this graph really summarizes it quite nicely. This study by David et al. You can see that the SALT score decreased from just above 50 down to 2.2 at the end of the study. But what's really important to recognize here is that hair growth occurs very slowly with dupilumab. At 6 months, that's a pretty long time. A lot of our hair loss studies were done at 6 months. You can see that not a great amount of improvement in hair growth at 6 months. Even at 9 months, not much, but we're getting better. But as we start getting into well over a year, year and a half, we're seeing that the SALT score is improving dramatically. And remember, a SALT score of 2 on average means 98% hair growth. And this particular figure from the paper, from David et al., really shows the results so nicely. It shows the very happy results of before and afters in these patients receiving dupilumab. And they received dupilumab at various doses according to their age-appropriate and weight-appropriate dosing. But you can see that some patients achieved tremendous improvement in their hair with dupilumab. What makes dupilumab quite an exciting therapy is that first, it's approved for children. It's approved for adults with atopic dermatitis that is severe. Second is that the side effect profile is reasonably good. It does have side effects. Keratoconjunctivitis, red eyes, itching, red face, other side effects. But the side effect profile is so dramatically different than the side effects of oral immunosuppressants. So much radically different than the side effects of JAK inhibitors or oral steroids. And in these 20 patients, dupilumab was well tolerated, with only 2 patients reporting mild side effects like joint pain and facial rashes, and these went away without treatment stopping. There was no serious adverse events in this particular study. So which patients on dupilumab therapy did better? Well, patients with a more severe alopecia areata score at baseline had a better response to dupilumab, and those with a higher IgE level also showed an earlier clinical response. The IgE level is also often associated with these allergic type responses, and studies have shown that patients with high IgE levels with alopecia areata often respond better to dupilumab, and this study verified that concept. Something very special about IgE levels, although patients with not high levels still can benefit from this medication. But all in all, the conclusion here is that dupilumab is effective and well tolerated in children with alopecia areata and atopic dermatitis, the so-called AAAAD phenotype, and leads to an improvement in the SALT score. It's a slow improvement, but nevertheless leads to an improvement in the SALT score in patients with alopecia areata and atopic dermatitis. Not a lot of big changes after 6 months, 9 months, but significant changes in the interval 1 year to 2 years. We have to remember that this study doesn't address the use of dupilumab in patients with alopecia areata that don't have atopic dermatitis. And that's an area where data is less clear, but certainly that may be an option in those patients as well, but more studies are needed. And we always have to keep in mind the possibility that dupilumab causes alopecia areata in some patients. But this group with the specific cytokine profile associated with alopecia areata and atopic dermatitis may respond to these particular medications. So I thank the authors for this very nice study, which highlights the use of this drug in this specific patient group. We'll be hearing more and more about dupilumab and alopecia areata in the months and years to come. We turn now to an interesting study looking at the use of ritlecitinib, the JAK inhibitor ritlecitinib or Litfulo, and how it stands up over 24 months of evaluation in the treatment of alopecia areata, a really important study. This study shows that ritlecitinib helps a significant number of people with severe alopecia areata and does so with reasonably good safety, at least from the data that we have so far. And what this study shows is that there is further improvements that occur between year 1 and year 2. And quite intriguingly, about 60% of individuals that start out with alopecia totalis and universalis can achieve a SALT score less than 20 or 80% hair growth after 24 months of use of this medication after 2 years. So a really important study which really captures the benefits of ritlecitinib in treating some pretty challenging forms of alopecia areata. The study also provides side effect data up until year 2 and is an important study in our understanding of how to use these medications. Ritlecitinib, baricitinib, ruxolitinib, these are the 3 FDA-approved treatments for alopecia areata in the severe form. So we're going to take a look at this study, but before we do, let's just back up a bit and remind ourselves about these JAK inhibitors. These are oral medications which block a specific pathway in immune cells known as the Janus pathway or JAK pathway. Baricitinib was approved on June 13th, 2022. It was the first FDA-approved systemic treatment for severe alopecia areata. Ritlecitinib was approved the next year. It goes by the name Litfulo, and that's the focus of today. Summer of 2023 was its approval time. And ruxolitinib was approved this year in summer 2024. Ruxolitinib is not available as it is currently undergoing legal issues regarding its patent. And so baricitinib and ritlecitinib are available to patients with severe alopecia areata. In many countries throughout the world, ruxolitinib is not. And what's important to remember as we go along here is that these drugs are approved for severe alopecia, meaning more than 50% hair loss. These drugs are not approved for milder forms and moderate forms, but sometimes are used off-label in those indications. So these are JAK inhibitors, and there are many JAKs, JAK1, JAK2, JAK3, TYK2, and these various JAK inhibitors, of which there's many, baricitinib, ritlecitinib, druxilitinib, upadacitinib, abrocitinib, deucravacitinib. These JAK inhibitors inhibit different JAK enzymes. Baricitinib inhibits JAK1 and JAK2, ritlecitinib inhibits JAK3, and another enzyme called TEC, and druxilitinib inhibits JAK1 and JAK2, similarly to baricitinib. And what all of these studies look at in their research protocol is what proportion of patients achieve a SALT score of less than 20 at the end of the study. And a SALT score of less than 20 means 80% regrowth. So what percentage of patients that start out with severe hair loss end up with 80% or more growth? And that's the same endpoint for the baricitinib study, the ritlecitinib study, druxilitinib study. So this graph shows the proportion of patients achieving a SALT score less than 20 at week 24. The orange dots show ritlecitinib, the green dot shows baricitinib. You can see that around a quarter of patients achieve a SALT score less than 20 at this 24-week time point. And then it rises at week 36, and it rises even further at the 1-year time point. For ritlecitinib, around 37% achieve a SALT score less than 20 at week 36, at 43% at week 48, 45% at week 52, or 1 year. And you can see that there's a slow increase in the proportion of patients that are getting some good results. And remember, a SALT score less than 20 doesn't mean full coverage. A SALT score less than 20 means 80% growth. Some hair loss may still be remaining. And as we go about talking about JAK inhibitors today, what's important to be aware of and keep in the mind is that there's two important questions which remain that nobody can answer. Today we're going to be talking about data at 2 years, but the two important questions are: how do these drugs stack up after 5, 10, 20 years of use, 40 years of use? Remember, these patients with severe alopecia areata probably need to use these drugs lifelong. We don't have a cure for alopecia, we have treatments, and once we stop the treatments, hair loss occurs in a large percentage of patients, especially totalis and universalis. So how do these drugs perform over a long term? And then what are the side effects? Today we're going to be talking about side effects after 2 years of use, but what are the side effects after being on this drug 5, 10, 20 years? We don't know that. JAK inhibitors have been around in the world for just over 10 years, tofacitinib being one of the front runners. We still use tofacitinib in alopecia areata. But here we have 2 years of study with ritlecitinib. We don't have 10. We don't have 20. So we have data for the 1-year outcomes. How do these drugs perform after 2 years of use, or 104 weeks? Does the orange line go up further? Does the orange line stay the same? Does the orange line go down? So this very nice study by Liang and colleagues summarizes the 104-week data for ritlecitinib for patients with severe alopecia areata. And what they showed is that after 2 years of use, 61% of patients with severe alopecia areata achieve a SALT score less than 20. So it continues to increase into year 2. And what was so interesting about this study is that 60% of patients with totalis and universalis to begin with achieve that salt less than 20 endpoint. Alopecia totalis and universalis are extremely challenging to grow with traditional treatments. Extremely challenging to achieve 2-year results with many of our agents in our current toolbox, like methotrexate, difencyprone. But here, 60% of patients achieved that endpoint with ritlecitinib, 50 milligrams once daily. And the proportion achieving a SALT score less than 10 or 90% growth was quite good at just around 50%. And these improvements in scalp growth parallel the improvements that were seen with eyebrow and eyelash growth. But what's important to be aware of as we review these JAK studies, whether it's baricitinib or ritlecitinib, is that not everyone retains their good results. About 20% of people who had nice results at the end of year 1 lost their results to some degree in year 2. So 20% who had a SALT less than 20 did not have a SALT less than 20 as 104 weeks rolled around. And we saw that with baricitinib. About 10% of patients on baricitinib lose their nice results. And so that's frustrating because it's frustrating for the patient. Imagine a patient that comes into clinic, they've been on the drug a year, they're achieving some nice results, and they say to you, is this my result forever? Am I going to retain this result? There's a good chance you're going to retain it. There's a small chance you'll lose some of this good growth. And what we need to keep in mind is we don't know the results for 5 years, 10 years, and 20 years. I'm 28 years old, doc. I'm so happy with this drug. Am I going to look like this when I'm 40? 50? We don't know. We've got 2-year follow-up data now. So a lot of unanswered questions in this field in general, but super exciting data for year 2. What were the most common side effects of ritlecitinib? Well, they're listed here. Headaches, 19%. Nasopharyngitis, upper respiratory tract infections, 13%. Acne, 11%. Cough, fatigue, hives, and urinary tract infections, oropharyngeal pain. So infections are an important part of the side effect profile. Most tend to be mild, but not all. And shingles occurred in 4.2% of patients. Shingles is herpes zoster. Serious infections occurred in 1%. Breast cancer in 2, melanoma in 1, cervical dysplasia, venous thromboembolism in 1. Now, of course, when we see cancers in any clinical trial, we can't always implicate the drug. Human beings develop cancer, human beings develop infections, human beings develop other side effects unrelated to the drug sometimes. But certainly it is an important thing that allows us to pay attention and prompts us to continue to follow this particular aspect. We know, and we mustn't forget, that in patients with rheumatoid arthritis using JAK inhibitors like tofacitinib, we know that there is an increased risk of cardiovascular disease, heart disease, blood clots, cancer, and death. And there's a boxed warning on the product monograph for tofacitinib in rheumatoid arthritis patients. And the question arises, do any of those side effects apply to our patients with alopecia areata? And so far, the data in the dermatology community in patients with alopecia areata, atopic dermatitis, and other indications has been pretty encouraging. That we don't see this same burden of side effects that we see in rheumatoid arthritis. But studies aren't over. We need to continue to follow this closely. Severe adverse events occurred in 9.4%, and serious adverse events occurred in 5.8%. So in the alopecia areata community, there are side effects that occur. 33% of patients needed to temporarily stop their drug because of side effects, and 10% needed to permanently stop because of side effects. So I think that's important because it reminds us that, out of every 100 patients that you prescribe ritlecitinib to, you should be expecting some patients are going to be needing pauses in their treatment plans, and some people are going to be needing to stop altogether. Fortunately, the numbers are reasonably low for permanent stoppage. So we've moved from week 52 data to week 104 data. We're moving down the road to understanding the longer-term issues associated with JAK inhibitors. The efficacy seems pretty good. It doesn't help everyone. There's 40%, 50% of people that, don't get as good of outcomes as they want. There are some people that don't respond well to JAK inhibitors. We clearly need to figure out why that is and how to help these patients, but a significant proportion of patients do respond to JAK inhibitors. We're coming to understand side effects of headaches and acne and nasopharyngitis. Blood count changes are not that common. There are serious infections and severe infections that occur. Some patients do need to stop. But these severe signals for blood clots, cancer, cardiovascular disease aren't really emerging at this 2-year data. Of course, long-term studies will be needed, and we'll need to continue to follow the long-term risk of JAK inhibitors in alopecia areata patients in terms of the risk for blood clots, cancer, cardiovascular disease. But the data is encouraging at this point in time. But I think it's important to be aware that we're at year 2. Our patients want data for year 22, 42. Why? Because these are lifelong drugs. And so if patients are going to take these drugs, they want to know, what's it going to be like if I'm on this drug 20 years? We don't have that data yet. So it's important to respect that. And as we go along, other JAK inhibitors are undoubtedly going to be approved as well. Baricitinib and ritlecitinib and druxilitinib are certainly not the final treatments in this new world that we have for targeted treatments for alopecia areata. Others are coming. And the question that will always be front and central is, how do they compare? Not only in terms of effectiveness, that's only part of it, but how do they compare in terms of safety? If one drug emerges that's super effective but not very safe, but another drug emerges that's pretty effective but incredibly safe, well, it's going to be the winner. So comparative studies will be important, and head-to-head studies will be uncommon for a long time, but there are ways of evaluating data through fancy statistical analyses. But both of those issues are extremely important. How do the drugs compare with safety and effectiveness? So I congratulate these authors for such a wonderful study, which brings us up to speed on the 104-week data and the really, really nice results that patients with alopecia totalis and universalis can get with ritlecitinib. Unfortunately, it's not enough patients, but in the present day and age, it's the best of its kind that we have. And a high percentage of patients can really achieve some wonderful results. So really exciting times in alopecia areata. We move now to 2 studies related to cardiovascular disease in alopecia areata. First study by Dr. Losico's group in New York, Noria et al., titled Alopecia Areata and Cardiovascular Comorbidities, a cross-sectional analysis of the All of Us research program. Really like this study. There's a tremendous interest in understanding whether alopecia areata is associated with cardiovascular disease. Some studies have suggested absolutely it is. Other studies have suggested no way. And so here we have a nice study which looks at this again. Back at the drawing board, asking the question, is alopecia areata associated with heart disease? And here the authors looked into the All of Us database to try to answer that question. And what they found is, no, there doesn't seem to be an increased risk of heart disease. There may have been an increased risk of kidney disease and some other side effects, but not heart disease. it's important to understand a few pioneering studies in this area of alopecia areata and heart disease, because these can't be ignored. The first is the CONIC study, a study in the Journal of the European Academy of Dermatology and Venereology in 2021 titled Prevalence of Cardiac and Metabolic Diseases Among Patients with Alopecia Areata, published in the Journal of the European Academy of Dermatology and Venereology. CONIC and colleagues used a very large database, and they compared 33,000 patients with alopecia areata to 57 million patients who didn't have alopecia areata. And they looked at a variety of health issues. And what they found is that patients with alopecia areata had a higher risk than controls of hypertension, diabetes, hyperlipidemia, coronary artery disease, atrial fibrillation, and stroke. And some of those risks were quite remarkable. And so the conclusion of the CONIC study was, alopecia areata is associated with heart disease. In the same year, a study by Lee and colleagues suggested, no, not correct from our view. Their study, titled Alopecia Areata is Not a Risk Factor for Heart Disease, a 10-year retrospective cohort study. Different study design, different way of looking at things, different patient population. But they looked at 3,770 cases of alopecia areata and 18,000 controls, matched 1-4. Here they found that alopecia areata was not associated with an increased risk of heart failure, angina, myocardial infarction. So these are two important studies that appear to conflict with each other. And as we go about looking at the risk of alopecia areata and heart disease, as we go about looking at the risk of scarring alopecia and heart disease, we have to develop a comfort in conflicting studies, because there's few areas of hair loss that are more conflicting than these. And so you can imagine that I've been following this area of cardiovascular disease literature quite closely. And so Noria comes out with this nice study in 2024, looking at the All of Us database and the risk of heart disease in patients with alopecia areata. They've used 995 cases of alopecia areata and matched them 1-4 with 3,980 controls. There were 74% females. The average age was 56. And what they found is that alopecia areata was associated with an increased risk of kidney disease, and alopecia areata was associated with an increased risk of hyperlipidemia, but it wasn't associated with an increased risk of cardiovascular disease like coronary artery disease, hypertension, or heart attacks. It was linked to kidney disease and hyperlipidemia. And so the authors point out that, why might this be? Well, could be because it is what it is. That's what it is. It could be because we have a significant proportion of women in this study, and maybe heart disease is missed in some way because of this skewed population towards females. The answer is we don't know. This data is what it is, and it shows that alopecia areata did not seem to be associated with an increased risk of heart disease in this particular study. And now we move to another nice study which asks the exact same question. A study by Caldas and colleagues in the Archives of Dermatologic Research. These authors set out to look at the same question. Is alopecia areata associated with an increased risk of heart disease? And again, they used the All of Us database. Same database as in Dr. Losico's study. Same database, different result. So let's dive in. They matched patients 1-4, just like in the Noria study. They found 1,000 patients with alopecia areata. They matched them to 4,000 controls. And compared to controls, there was a significant association between alopecia areata and cardiovascular disease, which held up in more sophisticated multi-regression analyses. The risk of cardiovascular disease was increased 1.82 times. And not only was the risk of heart disease increased, but ischemic heart disease specifically was increased compared to controls, cerebrovascular disease, and patients with both cerebrovascular and ischemic disease had an increased risk, was increased in alopecia areata patients. And the authors looked at patients specifically with alopecia totalis and universalis, severe forms, to look at their risk of cardiovascular disease. And what they found is that patients with severe disease with alopecia areata had an even greater risk of cardiac disease, cardiovascular disease. Again, supporting this notion that there's a relationship between alopecia areata and cardiovascular disease. So I really like these two studies. These studies and, the Connick and the Lee study in 2021, didn't sit well with me when they came out in 2021. How do we rationalize two studies that are so different in the advice we give patients? Well, I have a whole new level of comfort now because this topic is not going anywhere. We are not going to decisively get this answer. But when you look at some of the beautiful studies that have been done, looking at the risk of cardiac disease and cardiovascular disease and endothelial disease in patients with alopecia areata, there's signals there that there's a risk. Several years ago, we reviewed some very nice work by Dr. Rudnika's group from Poland, looking at changes in endothelial function in patients with alopecia areata, showing there's differences compared to controls. Other studies showing differences in certain markers in patients with alopecia areata. So I don't think we're there yet. And one can imagine, the possibility of a meta-analysis being done, which comes to yet another conclusion that, there's no risk. When you have studies that show yes and studies that show no, somewhere in the middle we're going to meet saying, no. But we don't really have that data, and this story is by no means over. And this story should by no means stop being studied. This is one of the extremely important subject areas in our field, understanding the risk of cardiovascular disease in patients with alopecia areata. This is very important. It's very important because we need to understand this, especially if we're giving patients with advanced alopecia areata systemic medications. We need to understand the baseline risk perfectly. And if we were to find, for example, that a medication increases the risk of heart disease, we need to be sure that the risk of heart disease wasn't increased at the beginning. Because if the risk of heart disease was increased in the beginning, then maybe it wasn't the medication that increased the risk of heart disease, maybe it's the patient's inherent predisposition to heart disease. So these are really important questions, and we'll be hearing more about this in the years to come as we continue to have elegant ways through large databases to study and address this question, but stay tuned. Such a unique situation here, same database, same patient population, different authors, different result. So we don't know. We don't know how to answer that question for our patients. Is alopecia areata associated with heart disease? We all have our opinions, but the literature is all over. So we move now to scarring alopecia as we round out our top 20 of 2024, beginning first with studies of frontal fibrosing alopecia. Frontal fibrosing alopecia is a scarring alopecia that affects women, ages from the teenage years up until 65 and 70. Certainly the most common age of diagnosis is between 45 and 58, but it can affect a wide age group of patients. It causes hair loss along the frontal hairline. That's how its name came about, but it causes hair loss at the back of the scalp. Most women develop hair loss in the eyebrows to begin with. It can cause eyelash loss, body hair loss. It can be associated with a whole host of other issues. and there are many, many comorbidities associated with FFA. Cause of FFA is not understood, but the incidence of FFA is thought to be increasing dramatically throughout the world. So a very, very nice study by Dr. Penha, last author Dr. Vanyo, looked at the use of oral minoxidil in frontal fibrosing alopecia. I really like this study. Highlights that oral minoxidil may help improve hair growth slightly and can be very well tolerated in our patients. And so it draws attention to the fact that in a stable patient who's doing quite well, the addition of oral minoxidil can bring about even further growth in the hairline. And one of the benefits of oral minoxidil is that it allows us in many cases to continue the use of a topical agent like topical pimecrolimus or a topical JAK inhibitor or periodic topical steroids. The introduction of topical minoxidil can be quite cumbersome, and it's not really clear how well topical minoxidil works in FFA. But the use of oral minoxidil removes another topical from, being needed to be used. Not everyone likes using topical treatments. Topical treatments can gunk up the hairline, and many of these topical agents require use quite frequently and become exhausting over time. And the use of oral minoxidil relieves some of that. So an extremely important subject to study. And so I congratulate these authors, and let's dive into this study. FFA has many treatments. Some of the first-line agents include finasteride, dutasteride, isotretinoin, hydroxychloroquine, steroid injections. And other second-line options are emerging too, like the JAK inhibitors, which we'll get into in just a minute. But the purpose of this study was to evaluate the effectiveness of low-dose oral minoxidil in FFA. And to do this, they studied 122 patients in this retrospective study, 112 women and 10 men. We should never forget that FFA can affect men, and the FFA literature includes about 10% men, and this study includes 10% men. The mean age at starting oral minoxidil was 56 years, and the dosage ranged from 1.2 milligrams per day in women to 2.7 milligrams per day in males. Always important to remember that females use a lower dose on average than in males. Females often start 0.625, even 0.25, and move up, and can move upwards to 2.5, but risk of side effects increase as we go beyond 1.25 quite dramatically. In males, the starting dose is 1.25 to 2.5, and moving upwards from there. The median duration of treatment was 6 months. How good was oral minoxidil? Well, 45% experienced an improvement in their hairline. And that improvement was classified as mild in 34%, moderate in 9%, and excellent in 2%. So about 10% have moderate to excellent growth. We mustn't forget, this is a scarring alopecia where we have, fibrosis and inflammation inhibiting the ability of little hair follicles to regrow. And many of these tracts in the scalp are permanently fibrosed, but those that are not are still working their way through scar tissue and inflammation. And so to have 45% of patients experience some improvement, it's a big deal. So I really like this study. What I also liked is that a quarter of patients had an improvement in eyebrows, and 3% had an improvement in eyelashes. So not great for eyelashes, but a quarter had an improvement in eyebrows. So very important. Our options for eyebrows are limited, but certainly greater than our eyelash toolbox. We have topical minoxidil, we have topical pimecrolimus, we have topical JAK inhibitors, all off-label. There's nothing approved for FFA. We have steroid injections. We have topical bimatoprost and prostaglandin analogs. And so to be able to have another tool that improves eyebrow growth is really important in our FFA algorithms. Side effects occurred in 33% of patients. The most common side effect, not surprisingly, was hypertrichosis. And as we reviewed earlier today, other side effects were seen. They included headaches, tachycardia, dizziness, fluid retention, periorbital edema, and excessive shedding. But the study nicely shows that this is a nice adjunctive treatment for FFA. And this slide shows first line, second line, and third line treatment options in our clinic for FFA. And you can see that the 5-alpha reductase inhibitors, isotretinoin, calcineurin inhibitors are at the top of the list, but we have oral minoxidil down here. It's really a very useful second line agent. And everyone has different views on how things are used in FFA. Tremendous number of different views. But in my opinion, once we get the disease under control, and once we've got evidence that we're winning, bringing oral minoxidil on board is a great option because it offers the potential for further stimulation of these hairs and further growth. And I thank the authors for this wonderful study which really validates where oral minoxidil fits in these treatment algorithms, and I think it's very much a part of a comprehensive approach to FFA. We move now to two very nice studies looking at the use of topical JAK inhibitors in frontal fibrosing alopecia. The first, a study by Chen and colleagues, last author Dr. Marianne Senna from Boston. Topical tofacitinib for patients with lichen planopilaris and FFA. Here, patients with both FFA and LPP, but a large percentage in this group did have FFA. The key message in this study is that topical tofacitinib can be helpful for LPP and FFA, and patients using it more often seem to do better. And let's dive in. The purpose of this study was to understand the effectiveness and any associated side effects with the use of 2% tofacitinib in LPP and FFA. So oral JAK inhibitors and topical JAK inhibitors have been studied for a while now in scarring alopecia. Studies have been small, but a number of studies have suggested that oral JAK inhibitors have some sort of a role in the treatment of lichen planopilaris and FFA, with FFA being a variant of LPP. The reason that the topical JAKs are so important to study is that the safety margin is enhanced dramatically. The systemic absorption is less with the use of a topical JAK inhibitors than a systemic JAK inhibitor. And so if we can achieve pretty good outcomes with a topical JAK, it will be a better option. And so the authors here set out to understand the benefits of 2% tofacitinib compounded in FFA. Again, not an FDA-approved treatment. There's no FDA-approved treatments at all for scarring alopecia. 37 female patients in this study, 4 male patients. Most were white. 75% had FFA. That's really important to be aware of as we come to understand that maybe these topical JAKs are better in FFA. But 17% had LPP-FFA overlap, and 7% had classic FFA. The average age at diagnosis was 58 years, and the mean disease duration was 5 years. Topical tofacitinib was used as the sole treatment in 25% of patients, and it was used as an adjunctive treatment in 75% of patients. The average duration of treatment was 9 months. 60% of patients used the tofacitinib topically 2 to 3 times a day, highly committed group. 40% used it 1 to 2 times a day, highly committed group. So that's important to be aware of as we think of this study and where it fits in. 2 to 3 times a day use of a medication is very significant. And that may be possible for many patients over a short run. But what we always have to keep in the back of our mind is the concept of treatment fatigue. Can patients keep up using 2 to 3 times a day for 2 years if we need it, 3 years if we need it, 4 years if we need it? But the point I make is that this is a very committed group using lots and lots of topical tofacitinib. The LPPAI was used to score the activity of the scarring alopecia. The LPPAI scores fell from 3.03 before treatment to 1.40 after treatment, and this represented a 48% decrease in the LPPAI score. So topical tofacitinib seemed to help LPP, but seemed to help FFA. About 31.6% of patients with FFA had an improvement in their hairline, and 60% had a stabilization. So a large proportion of patients had some kind of benefit with topical tofacitinib. Side effects were mild, but were limited to irritation and acne. Irritation in 2 patients, acne in 1. I think this is really important too, because what we're going to see is that some of the important side effects with topical JAKs is irritation. And one thing we'll need to figure out over time as topical JAKs become part of our toolbox is how best to deal with irritation from topical JAKs, because people are stopping these drugs because of irritation. And so we need to figure out strategies to deal with irritation. Topical JAKs will likely be part of our toolbox in years to come, and so these kinds of studies are super important. But I really like this study. I congratulate Dr. Chen and Dr. Senna. This clearly shows that topical tofacitinib does something. Patients in this study were using it often, 60% getting it on the scalp 2 to 3 times a day. That's really important because topical tofacitinib right now is not cheap, and topical JAK inhibitors aren't cheap. And if ever approved for scarring alopecia, it won't be cheap. And so if you use it twice a day, it's going to be twice as expensive as if you use it once a day. If you use it 3 times a day, it's going to be 3 times as expensive as you use it once a day. And so paying attention to that information is really, really important because it reminds us that we need to use these often to get some nice results. We're going to see that theme when we talk about baricitinib next. But what nice results. 30% of patients get an improvement in the hairline. 60% stabilize. The whole new world of JAK inhibitors, the whole new world of thinking about FFA with oral minoxidil, JAK inhibitors, dutasteride, even other treatments like hydroxychloroquine, we're realizing that, some patients do get an improvement. Some patients do get a slight improvement. These injured hairs, these inflamed hairs that are trying their best to survive, some of them do come back. Now, it doesn't all come back. But regrowth is an important parameter to be thinking about. And 30% achieve some types of regrowth. What's so important in studies of FFA is the long-term data. And I'm always skeptical of FFA studies because of the follow-up. FFA is one of those conditions that it can sometimes fool you. It can sometimes be pretty quiet looking, and then it acts up, and then you've got movement of the hairline. It can sometimes look quiet. Redness is gone, inflammation, irritation's gone, patient feels great, and you do measurements, and you find this hairline is moving back. And the patient says, really? I don't feel anything. The redness looks so much better. I know, but the hairline's moving back. So long-term studies are really important in FFA. And that includes studies that include time points over 2 years. But certainly these types of studies here are really important and really help push us forward in understanding how JAK inhibitors fit in the treatment of FFA. And so I congratulate these authors. The other issue with topicals is that there's so many topicals that are compounded. And topical tofacitinib in my clinic can be made up 4 different ways. I have a clinic, I have a pharmacy, one side of the country, the other side of the country, this province. I can make up 4 different topical tofacitinibs. And they're all different. They're not the same. One is more drying, one's more irritating, one's more aesthetically nice. Which one's better? No one knows. And so there's going to be different formulations, and we have to keep in mind that some may be different. So the topical tofacitinib that I use might be different than the topical tofacitinib in this study. And that is important to understand as a general concept for compounding. When you hear studies of topical finasteride in India is different than the topical finasteride in the eastern United States, and the topical finasteride in the eastern United States, New York, is different than the eastern United States in Maine. And the topical finasteride in the eastern United States in Maine on 4th Street is different than eastern United States, Maine on 8th Street. So there's 100,000 formulations of topical finasteride. And there's 800 topical tofacitinib formulations. So that's a real challenge in the world. Is we have to always remember that these topical formulations are different. But congratulations to these authors for such a wonderful study. We move now to another similar type study. Williams et al. Last author, Dr. Antonella Tosti, titled Topical Ruxolitinib in the Management of FFA and LPP, a single-center retrospective study. Published initially in the fall of 2024. This study showed a very similar finding, and that is that topical JAK inhibitors, here ruxolitinib, have benefit in the treatment of lichen planopilaris and frontal fibrosing alopecia. So here the authors didn't look at tofacitinib, they look at ruxolitinib, a 1.5% cream. Ruxolitinib is now approved for vitiligo and eczema as this cream known as Opzelura. And so they wanted to know how well Opzelura helps patients with frontal fibrosing alopecia and lichen planopilaris. They identified 20 patients that used topical ruxolitinib, 15 female, 5 male, 30% had LPP, 40 had FFA, and 30% had both. The mean age at diagnosis was 48 years, and the mean disease duration was 60 months. The mean duration of using the topical ruxolitinib was 9 months, but it ranged from 3 up to 24 months. Patients used ruxolitinib for varying numbers of times per day. 20% used it twice a day, 45% used it once a day, and 35% used it every other day. And so here, in this Williams et al. Study, we can see that the use of the topical JAK inhibitor is less than in the Chen et al. Study. In the Chen et al. Study, 60% were using it 2 to 3 times a day, and 40% were using it 1 to 2 times a day. So here, in the Williams et al. Study, patients don't use it as often. And that's important because the reduction in the LPPAI was less. The LPPAI fell 34%, from 2.7 to 1.7. 7 patients had a 25% reduction or less. 9 had a 25 to 75% reduction in the LPPAI, and 4 had a greater than 75% reduction. And there was a trend, a non-statistically significant trend, that patients that used more ruxolitinib had a greater reduction in their LPPAI scores. 2 patients had scalp irritation, and 1 patient stopped due to this irritation. Again, emphasizing that irritation is now part of our lingo for topical JAKs. We need to be thinking about this. We need to be counseling patients about it. And we need to develop strategies to make these JAKs tolerable for everybody, Fortunately, the irritation is not super common, but it does occur in a good number of patients. This slide shows that patients with FFA seem to respond better to JAK inhibitors, and that patients that were getting a 75% reduction in their LPP-AI or their activity were largely those with FFA. And patients with LPP responded a little less well. And this slide shows that patients that get the cream on the scalp more often do better. So 75% of patients using it twice a day had some really nice results. Patients using it every other day, nobody had these fabulous results. It still works, but the outcomes are not as fabulous. So it's a nice reminder that as we move into this era of topical JAKs, which very much is an era, these next few years will be an era of JAK inhibitors. The important thing to be aware of is this isn't a treatment that you use Mondays and Fridays. That these topical JAKs work when you use it Monday 3 times a day, Tuesday 3 times a day, Wednesday 3 times a day, Thursday, Friday, Saturday, Sunday 3 times a day. It does work when you use it 2 and 1 and 0 and every other day, but much less effective. So the amount that you get on the scalp influences it. And so what we always have to be aware of when we're getting stuff on the scalp more often is, do we get any systemic absorption? And if we do we? And does using a topical JAK in large proportion of patients bring about, in this population, which is a different population than vitiligo and atopic dermatitis, an increased risk for things like shingles? Does using a topical JAK in a 61-year-old with FFA 3 times a day bring about any bit increased risk of shingles? We need large numbers of patients to study that because the risk of shingles in this population is so low to begin with, but those are all questions for the future. But the main message now, topical JAKs seem to help FFA, LPP, seem to help FFA more, and the more you get this medication on the scalp, the better that it works. And so I thank these authors for this wonderful, wonderful study. And we need to keep in mind that it could be that topical tofacitinib seemed to perform better because patients in the Chenadel study were using it more often. But congratulations. We move now to studies in central centrifugal cicatricial alopecia, or CCCA. CCCA is a scarring alopecia that predominantly affects Black women. It starts often in the central scalp and moves outwards over time. Other areas can be involved, but the most common presentation is a scalp central type hair loss pattern. Usually starts in the early 30s. First line options include steroid injections, topical steroids, doxycycline, topical minoxidil, and useful second line options are shown here, including oral minoxidil, metformin, and JAK inhibitors. But doxycycline, steroid injections, minoxidil, topical steroids form the key set of treatments for CCCA. So a very nice study in the Journal of the American Academy of Dermatology by Obi and colleagues looked at the benefits of doxycycline in patients with CCCA. And the key message of this study is that doxycycline appears to be beneficial. And what was unique about this study is the benefits of low-dose doxycycline, the sub-antimicrobial doses of 40 milligrams, 20 milligrams twice a day, Periostat, the 40 milligram doses of Arrhythmia, that can be helpful in CCCA. The traditional doses of doxycycline that have been used have been the antibiotic doses, 100 milligrams once to twice a day. And those can be effective. Those typical doses can be limited by GI side effects and other side effects like yeast infections. and change in the gut microbiota. The benefit of lower doses of doxycycline, like studied here in the Obi et al. Study, is these subantimicrobial doses don't impact our gut flora to the same extent. So the authors set out to evaluate the effectiveness of doxycycline in CCCA. There was 143 patients in this retrospective review. These were divided into two groups, one which received doxycycline, there was 115 in that group, and one which did not. There was 28 in that group. And both groups received topical steroids and steroid injections to varying degrees. And what makes this study a little challenging is that to varying degrees differs. Not everyone received steroids in this group, not everyone received steroid injections, not everyone received steroid injections in this group, and not everyone received topical steroids. But nevertheless, the message is that those receiving doxycycline seem to do better. Clobetasol was the most common steroid. 73% in Group 1 received clobetasol, compared to 57% in Group 2. 29% in Group 1 received steroid injections, compared to 39% in Group 2. And steroids were given to varying frequencies. But the most commonly employed doxycycline was the subantimicrobial doses. And these included doses of 40 milligrams daily, 40 milligrams twice daily, and 20 milligrams twice daily. And so you can see that the proportion of patients receiving the 100 milligram or more doses is very, very low here. I think that's super important. And what the authors found is that a statistically significant higher number of patients in Group 1, the doxycycline group, achieved an improvement in hair density compared to Group 2. And the average time to growth was around 6 months. So a really interesting study. It puts low-dose doxycycline on the map as a useful option in CCCA and something that we need to consider. And perhaps as we say doxycycline in our list of options for CCCA, we should be saying doxycycline/low-dose doxycycline as a reminder that we have that option and as a reminder that may provide benefit as well. Now, clearly we need studies that definitively compare the two, and clearly we need randomized studies that evaluate this in isolation. But this is an important study which gets us thinking about the role of doxycycline. Because I think that, in my clinic, doxycycline steroid injections, minoxidil, topical steroids are really, really important for CCCA. And despite all the excitement about, topical JAKs, topical metformin, oral metformin, nothing comes close to what can be achieved with doxycycline, steroid injections, and topical steroids, and minoxidil in CCCA. These are fundamental treatments, in my opinion. And this study really puts doxycycline on the map, that it's there. And I think a lot of people are concerned about doxycycline for a good reason, because of the GI side effects and effects on the microbiota. But the low-dose doxycycline forms really have minimal to no impact on those flora, those gut bugs. So I think this is really important. This study is challenging. The steroids differ in both groups. So Group 1 and Group 2 don't receive the same amount of topical steroids. They don't receive the same amount of steroid injections. And we don't know the follow-up duration in this study in a meticulous manner. So it's challenging to interpret, but nevertheless has some really important messages for us. And the authors call for clinical trials to understand the isolated role of doxycycline. And I thank the authors very much for this wonderful study, which keeps doxycycline on the list as a good option for CCCA. We move now to another nice study by Bao and colleagues, last author Dr. Agu, titled Low-Dose Metformin and Profibrotic Signatures in Central Centrifugal Cicatricial Alopecia. A really wonderful study which highlights some of the molecular changes that are occurring in patients that have very refractory disease that are treated with low-dose metformin, and brings to attention the potential benefits of metformin to help address possibly inflammation and possibly fibrosis in patients with this disease. So we need novel treatments in CCCA. Not everyone responds to doxycycline, steroid injections, topical steroids. What do we do in these refractory cases? Well, our list starts dropping off dramatically of what to use. There's been studies in JAK inhibitors. There's been studies in PRP. There's been studies in topical calcineurin inhibitors. There's been studies in topical metformin. There's been studies in oral metformin. But the quality of evidence really drops off dramatically in terms of the number of studies and the quality of those studies. And so Dr. Gu and her group set out to evaluate how well low-dose metformin works in CCCA and understand the molecular pathways that are affected by treatment. So the group set out to assess the clinical effects of metformin and the changes in gene expression with metformin. And these are patients that have refractory disease. They don't respond to standard treatments. They're a challenging group to start with. And they evaluated data from 12 patients with confirmed CCCA. Patients were given metformin, 500 milligrams extended release formulations for at least 6 months, and they looked at a variety of parameters. And what they found is that there was a little bit of hair growth that occurred. Of the 12 patients, 9 had a little bit of improvement in their symptoms, and 6 had a little bit of improvement in the hair growth. So about half of patients with very challenging disease had a little bit of improvement. Not a lot, but a little bit of improvement with growth. But there was changes in gene expression. There was changes in hair growth promoting proteins, like the keratin-associated proteins. There's an increase in expression of those. A downregulation in genes related to fibrosis. A very, very intriguing finding of this study. Downregulation of genes like MMP7 and collagen 6A. And a change in other pathways related to inflammation and growth metabolism. So I think this is, really an interesting study, which shows that as we move forward with CCCA especially, that thinking about pathways related to fibrosis, may be very relevant. CCCA seems to have an inherited predisposition towards fibrosis and abnormal scarring. Increased risk, for example, of fibroids in women with this disease that Dr. Agu nicely showed a number of years ago. But there's something very special about fibrosis, and this study shows that metformin addresses some aspects of that fibrosis. Of course, larger studies are needed. This is a pilot-type study which really sets us off thinking that these may be very important tools in the toolbox that address not only inflammation but fibrosis. And so I congratulate these authors for this very nice study. Topical metformin is very much an important topic in the CCCA literature, as we understand the role of topical metformin and we understand the role of oral metformin and how these fit in. Low doses of oral metformin tend to be very, very well tolerated. This is a cheap, readily accessible medication, and side effects tend to be quite low in patients that are healthy. And so this is really an important study. What will be important to understand is how do things change if we use higher doses? And Dr. Agu's group showed that we get these changes in gene expression. But one wonders, do we get these same changes in gene expression with people that don't respond at all to these drugs? So are these changes in gene expression correlated with the responses that we see? And so more studies will be coming. as we understand the role of topical and oral metformin in CCCA, and I thank the authors very much for this study. Move to our final three, Folliculitis decalvans and 2 studies in lichen planopilaris. Folliculitis decalvans is a scarring alopecia. It can affect men and women. Men tend to be more commonly affected than women. It can affect any part of the scalp. The crown is often more affected than other regions, but it can affect the frontal scalp. It can affect the beard. It even affects, skin of the extremities, although that's less common. Cause is not clear, but it's thought that bacteria like Staph aureus have an important role in Folliculitis decalvans, and for some reason, Staph aureus and bacteria set up shop on the scalp, and this affects the response of the immune system to these organisms. And the body cannot completely eradicate Staph aureus in patients with Folliculitis decalvans, and that's where we need to step in and help. But even with antibiotics and even with treatments, this disease continues in some cases because of the altered microbiota that occurs in these patients. And so a very nice study by Isabella Doce set out to look at the role of hydroxychloroquine, titled Hydroxychloroquine May Be Beneficial as an Adjuvant Therapy for Folliculitis decalvans, a 5-year retrospective study in 49 patients. A really important study which brings to light the role of hydroxychloroquine, which you might know as Plaquenil, in the treatment of Folliculitis decalvans. The traditional options for Folliculitis decalvans include things like antibiotics, isotretinoin. Sometimes we move to steroid injections. This study is so unique because it draws attention to an agent that is traditionally used to chase away lymphocytes, an anti-lymphocytic agent, which we use in FFA and LPP and discoid lupus and systemic lupus. But we're beginning to learn that lymphocytic inflammation has an important role in Folliculitis decalvans, especially chronic Folliculitis decalvans. And the focus on the neutrophilic inflammation and the pustules becomes less relevant sometimes as time goes on. We call that the LPP Folliculitis decalvans phenotypic spectrum. So hydroxychloroquine is a drug that has immunomodulating ability. Safety is reasonably good. It, of course, does have some potential for retinopathy or eye-related side effects after many years of use, but those risks are low, and with proper ophthalmologic follow-up, seeing an eye doctor periodically, those risks can be kept very low. And this study really sought to figure out where hydroxychloroquine fits in the algorithms for Folliculitis decalvans. So the purpose of this study was to understand the outcomes of patients treated with antibiotics and hydroxychloroquine compared to patients that were just treated with antibiotics alone. So there were 21 patients treated with antibiotics and hydroxychloroquine, and there were 28 patients treated with antibiotics alone. The antibiotic of choice here, trimethoprim sulfamethoxazole. And the authors point out that in Brazil, that is an important agent for Folliculitis decalvans. So 49 patients in their retrospective review, 39 men, 10 women, not surprising as that is a very typical distribution in Folliculitis decalvans. Patients ranged in age from 20 to 73 and all had biopsy-proven Folliculitis decalvans. Patients were treated either with oral antibiotics at the typical dose or antibiotics plus hydroxychloroquine. Group 1 again, antibiotics plus hydroxychloroquine. Group 2, antibiotics alone. And patients also used topical clobetasol and ketoconazole shampoo. What were the results? Well, the data showed that patients treated with oral antibiotics and hydroxychloroquine achieved better results. And this is shown on the left. Patients treated with oral antibiotics and hydroxychloroquine, 52% of them had at least one relapse. but that was 93% in the oral antibiotics alone group, no hydroxychloroquine. It took 36.6 months on average until the first relapse, and that was 9.5 months to the first relapse in those treated with antibiotics alone. And so hydroxychloroquine may indeed be an option for folliculitis decalvans. And the authors point out that more research is needed to understand how this agent fits in our traditional algorithms. I think this is a really important study that really shows that sometimes we can achieve successes initially with our pustules and our scaling and our crust. But then what do we do for the long-term management, and what do we do to help patients that are flaring? Well, this change in flora and this lymphocytic inflammation may become very, very relevant, and agents like hydroxychloroquine may play an important role. And that may be why agents like steroid injections are so helpful in folliculitis decalvans, and why studies are showing agents like apremilast and baricitinib, JAK inhibitors, are helpful in folliculitis decalvans. It could be that targeting this inflammatory component is helpful. The good news about hydroxychloroquine is it's been around a long, long, long time. It's not approved for folliculitis decalvans. We don't have any approved treatments, but it's been around a long time. The safety is understood. Not completely safe, but reasonably good safety. And the availability is good. And on account of its long-term use, the cost is reasonably good. So I congratulate these authors for such a wonderful study which highlights the role of hydroxychloroquine in folliculitis decalvans. We move now to our final studies, looking at heart disease and scarring alopecia. We talked first about heart disease and alopecia areata, looked at the NORIA study, showing the fact that we had no evidence of an increased risk, and we looked at another study showing an increased risk in alopecia areata. Now we look at heart disease and scarring alopecia. Beginning first with a very nice study by Kim and colleagues in the Journal of the Investigative Dermatology. Is heart disease increased in patients with scarring alopecia? The take-home message of this Kim et al. Study was yes, it is. It's increased in many of these scarring alopecias. So the authors performed a cohort study of 406,000 patients, including almost 8,000 with primary scarring alopecia and almost 80,000 with non-scarring hair loss, and some 319,000 controls. These patients were from the National Health Insurance Service database in South Korea, a wonderful database that's used in much hair loss research. The scarring alopecias that were included pseudopalative Brock, LPP, folliculitis decalvans, dissecting cellulitis. The mean age of patients was 36 years. 65% of patients were men. And after adjusting for a lot of confounders, all the factors that can affect the risk of heart disease and cardiovascular disease, the authors felt that primary scarring alopecia is associated with a risk of heart disease. It's associated with a 18% increased risk of cardiovascular disease and 26% increased risk of coronary heart disease. And when the authors looked specifically at the subtypes of scarring alopecia, they found that there were specific risks. Patients with folliculitis decalvans had an increased risk of cardiovascular disease and stroke, 29% risk of cardiovascular disease, 39% risk of stroke compared to controls. Patients with LPP had a 93% increased risk of coronary heart disease compared to controls. Some did not have an increased risk. Dissecting cellulitis was not associated with an increased risk in this database, nor was pseudopalative Brock. And when the authors looked at sex-specific differences, they found that most of this risk is in men. That it is males with primary scarring alopecia that seem to be driving this increased risk of heart disease. But all in all, the authors here, Kim et al. 2024, proposed that primary scarring alopecia is a risk factor for cardiovascular disease. And I congratulate these authors. A really nice study which, reminds us that this is a really important study subject of cardiovascular disease and these inflammatory diseases. These scarring alopecias are systemic inflammatory diseases, and our theory is that many of these systemic inflammatory diseases bring about this increased risk of many metabolic issues and increased risk of heart disease. But we leave on a note with this study, a study published in Clinical and Experimental Dermatology titled Association of Lichen planopilaris with Cardiovascular and Metabolic Disorders, a Systematic Review and Meta-Analysis, a study which shows us, as its summary, that it doesn't appear that in a meta-analysis that lichen planopilaris is associated with an increased risk of cardiovascular disease, in stark contrast to the Jimenez study. But here we have a meta-analysis, a study which summarizes and brings together all of the data from many studies. So the studies are quite varied. I reviewed with you the Koenig et al. Study looking at the risk of heart disease and alopecia areata. I'd like you to know about the Koenig et al. Study looking at the risk of heart disease in lichen planopilaris, a study dating back to 2021, which was another wonderful study using a large database that showed that patients with lichen planopilaris have an increased risk of hyperlipidemia, high blood pressure, obesity, diabetes, and a 10-fold increased risk of metabolic syndrome. And this link between scarring alopecia, lichen planopilaris, and heart disease was not limited to the Koenig study. Joshi et al. Showed in 2022 that patients with lichen planopilaris and FFA together have an increased risk of ischemic heart disease, insomnia, hyperlipidemia, hypothyroidism, high blood pressure through their use of the All of Us database. And so now we have a study looking at the relationship between LPP and cardiovascular disease in a meta-analysis, pooling all of the published studies that meet the author's criteria. They found 10 case control studies involving 7,516 patients with LPP, and they compared them to 64 million controls. And what did they find? Well, they found there's no significant association between LPP and hypertension, diabetes, hyperlipidemia, obesity, and heart failure. So when you take all those studies, you smush them together, and you analyze the statistics as a group, you fail to see that association for cardiovascular disease risks. I think this is really important. I think that it certainly reminds us that, we cannot conclude from this study that lichen planopilaris and its variants don't have an increased risk of heart disease. But I think it certainly is encouraging that, this meta-analysis fails to show that increased risk. But, some of the data is quite striking. And I think this, just like the data for alopecia areata, is not over, and we need more studies of this area. And I thank the authors very much for this study. And that brings us to the end of the top 20 studies of 2024. I want to thank you so much for your attention today. We reviewed a number of wonderful studies in both non-scarring alopecia and scarring alopecia, which are changing how we think about hair loss, changing how we diagnose hair loss, changing how we treat hair loss, and changing the type of counseling that goes on in the clinic and the discussions that we have with patients. I want to thank you so much for attending today, and I will now open up to any questions that you may have